Hi everyone, welcome to another ICD-10 CM Coding Guidelines session. Today we're going to be focused on Chapter 9, which are the diseases of the circulatory system, code I00 through I99. Want to give a disclaimer before we begin. This section is pretty long, so it's not going to be 5 minutes, more like 20 to 25 minutes because there's a lot of information that we need to cover. So first up, one of the major diseases in this particular area is going to be hypertension. And so when you look up the main term of hypertension, you'll see that I10 is our code for situations when the patient has a diagnosis of hypertension. So, as it relates to ICD-10 CM system, the code set presumes a relationship between hypertension and heart involvement and hypertension and kidney involvement. In your ICD-10 CM code manual, in the alphabetical index, the two conditions, heart and kidney, are linked by the term with. So if you go over to your alphabetical index and you look at hypertension, you'll see an option for hypertension, heart disease, hypertension with chronic kidney disease. Per guidelines, these conditions should be coded as related, even in the absence of provider documentation that explicitly links these two conditions together. Of note, if the provider states that they're not related, of course, you are not going to link them. For hypertension and conditions not specifically linked by those relational terms, and you learned about these terms before, terms such as with, associated with, or due to, specifically in the classification, the provider has to link those conditions. So if you don't see that linkage in the alphabetical index, you don't link them together. All right, so now guys, let's talk about hypertension with heart disease. If your patient has hypertension with heart disease classified to category codes I50, I51.4, I51.7, I51.89, and I51.9, they are assigned to a code from category I11, and I11 is hypertension with heart disease. The classification also instructs us to list an additional code from category I50 for those patients with heart failure, and again, unless the provider does not say that they're related, they are assumed to be related by the classification. So now you may be asking me, so does that mean I don't use I10 in this particular situation? You're absolutely correct. No I10. You're going to use I11 and then a secondary code for the heart failure or any of the other conditions that are listed here. All right, hypertension with CKD. So remember I said the ICD-10 code set presumes a relationship between hypertension with heart disease and hypertension with kidney disease. Notice here, instead of code family I11, I'm giving you code family I12. So when the patient has hypertension and a condition that's classified to a code from category N18, which is your CKD are present, you're going to be using code I12. Now, of note, if the provider indicates that the CKD is not related to hypertension, you don't use this I12. So if he does not say anything, you're going to use I12. Then, of course, you're going to use the appropriate code from category N18 to as a secondary code to identify the stage of the CKD. So that's what N18 code family is all about, is the different stages. If the patient has hypertensive chronic kidney disease and acute renal failure, an additional code for renal failure is utilized. Of note, when we're talking about code N18.6, there is a tabular list instruction about adding code Z99.2, and I know that you're going to take a look at that code to see what that code describes. So let's pause for a second. We're talking about hypertension and heart, I11, hypertension and CKD, I12. Now, what about those situations when the patient has both hypertensive heart and CKD? Here, we have a combination code, I13, which is hypertensive heart and CKD. If heart failure is present, you're going to assign an additional code from category I50 to identify the specific type of heart failure. Also, the appropriate code from category N18, CKD stages, will be utilized as a secondary code to identify the stages of CKD. Now, I want to tell you that there are some excludes notes at I13, this is in your tabular list, that specifies the conditions included at I11, I12, and I13. And it basically is telling you if they have the conditions in I11 and the conditions in I12, you're going to be using I13. Also with this code family, if your patient has acute renal failure and CKD, you're going to assign an additional code for that CKD. That's a lot, guys. Really, this is what I recommend. Go over to your tabular list. Look at I10. That's just straight hypertension, no heart or kidney involvement. And then look at your code options for I11, I12, and then I13. Next up, hypertensive cerebrovascular diseases. In this particular situation, you're going to first assign the appropriate code from categories I60 to I69, followed by the appropriate hypertension code. Now, let me show you in a diagram format what that looks like. I'm sure many of you are visual like me. So I60 to I69, and then you're going to use a secondary code for the appropriate hypertension code. Something just kind of as a sidebar. If you're not familiar with the codes in I60 through I69, I highly recommend that you take a look at them because they have some similarities and they have some differences. And if you know up front what those similarities and differences are, it will help you with more accurate code assignment, which is the name of the game, right? All right, next up, hypertensive retinopathy, code family H35. Here, you're going to report your H35, which is background retinopathy and retinovascular changes, and then a second code for the systemic type of hypertension, so whatever hypertension your patient has. Of note, sequencing is based on the reason for your encounter. Next up, we have hypertension secondary. Secondary hypertension is actually due to an underlying condition. And in this situation, two codes are required. One, to identify the underlying etiology, and then two, a category code I15 for the type of hypertension. Again, here, sequencing is going to be determined based on the reason for the encounter. Transient hypertension. Three codes we want to look at here and related guidelines. So R03.0 is only used when the patient has an elevated blood pressure reading without the diagnosis of hypertension. If the patient has an established diagnosis of hypertension, you're not going to use R0 3.0. You're going to use I10 instead. We also have code 013 family, which is for gestational hypertension without significant proteinuria, and 014 preeclampsia for transient hypertension of pregnancy. Hypertension controlled. Hypertension controlled is essentially stating that the patient has hypertension and it's under control by therapy. In these particular situations, you are going to assign the appropriate code from those same code families. I think you know them by now. I10, plain old hypertension. I11, hypertension, heart. I12, hypertension, CKD. I13, hypertension, heart, and CKD. And I15 is your secondary hypertension. Then we have hypertension uncontrolled, and this refers to untreated hypertension or hypertension that's not responding to a current therapeutic regimen. Of course, you're going to assign the appropriate code based on your patient's condition. Next up, we have hypertension and crises. So hypertensive crises is category I16, and you're going to use this code when the provider documents hypertensive urgency, hypertensive emergency, or unspecified hypertensive crises. In addition, if the patient has any identified hypertensive disease, i.e. a condition from one of the 5 categories, you're going to assign those codes as well. And your sequencing is going to be based on the reason for the encounter. All right, so next up, we're going to look at pulmonary hypertension. Pulmonary hypertension is classified to category I27, which is other pulmonary heart diseases. In those situations, when your patient has secondary pulmonary hypertension, you're going to be using I27.1 or I27.2 code family. And then you're also going to code any associated conditions or adverse effects of drugs or toxins. Of note, sequencing is based on the reason for the encounter, except if it is an adverse effect of drugs. That is a guideline that will be covered in Chapter 19. Next up, atherosclerotic, coronary artery disease, and angina. For these 2 conditions, the ICD-10 code set has a combination code, and that code is either I25.11, which is arteriosclerotic heart disease of the native coronary artery with angina pectoris, and I25.7, which is atherosclerosis of coronary artery bypass graft or grafts, and coronary artery of a transplanted heart, but still with angina pectoris. And you learned about these combination codes or types of combination codes previously. When you are using any one of these combination codes, it is not necessary to report an additional code for the angina pectoris because it's already included in the code. The ICD-10 code set assumes a relationship in these 2 conditions, unless the provider states otherwise. If the patient has coronary artery disease and they're admitted due to an acute myocardial infarction, the acute myocardial infarction should be sequenced before the coronary artery disease. And we're going to talk about myocardial infarction shortly. Intraoperative and postprocedural cerebrovascular accidents. Now, just like any other post-procedural or intraoperative situations, the medical record documentation should clearly specify the cause and effect relationship between the medical intervention and the cerebrovascular accident in order to assign a code for intraoperative or post-procedural cerebrovascular accident. Your code assignment is going to depend on whether it was an infarction or a hemorrhage and whether it occurred intraoperatively or postoperatively. If it was in fact cerebral hemorrhage, code assignment is going to be based upon the type of procedure that was performed. Speaking of cerebrovascular disease, category I-69 is used to indicate conditions that are classifiable to categories I-60 to I-67. Remember I said earlier to take a look at I-60 to I-67? Very important, and you see why now. So I-69 can be used as the cause of the sequelae, aka the neurologic deficits themselves classified elsewhere. What does that mean? So one example of a neurologic deficit is hemiplegia. So what they're saying is category I-69 is utilized to indicate those particular classifications. But if your patient didn't have a CVA, but they had hemiplegia, you would report a different code. So they're telling you that this is used when the patient actually is having a sequela, a sequel to the late effects. So these late effects include neurologic deficits that persist after the initial onset of conditions that are classifiable to I-60 to I-67. So I know you're thinking, oh, I didn't look at I-60 to I-67. I should go and look at that now. You're absolutely correct. So the neurologic deficits caused by the cerebrovascular disease may be present from the onset, or guys, they could arise at any time after the onset of the conditions classifiable to you know who, I-60 through I-67. Codes in family I-69, which are the sequelae, they specify hemiplegia, hemiparesis, monoplegia. They also identify whether the dominant or non-dominant side is affected. You guys may recall us talking about this in the nervous system. Now, should the affected side be documented but not specified as dominant or non-dominant, and the classification system does not indicate a default, code selection is going to be very similar to what we saw in the nervous system. For ambidextrous patients, you're going to use dominant. For left side being affected, non-dominant. Right side being affected, the default is dominant. Additionally, guys, codes from category I-69 may be assigned on a health record with codes I-60 to I-67 if the patient has current cerebrovascular disease, but then they also have deficits from an old cerebrovascular disease, meaning they had a cerebrovascular disease, they had some deficits, and now they have another one, but they still have some of those deficits left over from the previous one. All right. Lastly, codes from category I-69 should not be assigned if the patient doesn't have any neurologic deficits. And that makes sense because if they don't have them, you shouldn't be coding them. Now, there is a code, Z86.73, which is personal history of transient ischemic attack and cerebral infarction. That's Z86.73. All right, on to acute myocardial infarction, AMI. The ICD-10-CM codes for a type 1 acute myocardial infarction identify the site. Examples can be anterior lateral wall. Subcategories I-21 or I-21.0 through I-21.2 and I-21.3 are used for type 1 ST elevation. And then we have I-21.4, and this is for a non-ST elevation myocardial infarction. So just to pause for a second, you see that I-21.0, I-21.2, I-21.3, that's for STEMI type 1 MI. STEMI, ST, elevation, myocardial infarction. But then we also have a non-STEMI, which is non-ST, elevated myocardial infarction. All right. And this particular code, I-21.4, I should also mention, is for non-transmural MIs in addition to non-STEMIs. Now, if the patient has a type 1 non-STEMI and it involves to a STEMI, you're going to assign the STEMI codes. Let's say that again. If the patient has a type 1 non-STEMI and it evolves to a STEMI, you're going to code it as a STEMI. If the STEMI converts to a non-STEMI due to thrombolytic therapy, TPA, it's still coded as a STEMI, right? Because once it goes there, we're still going to code it that it has converted. For encounters occurring while the myocardial infarction is equal to or less than 4 weeks old, and that's including any transfers to another acute setting or post-acute setting, and the myocardial infarction meets the definition of other diagnoses, we can still continue to report a code from category I-21, but it has to be equal to or less than 4 weeks old. In situations where we're beyond the 4-week time frame and the patient is still receiving care related to that MI, myocardial infarction, the appropriate aftercare code should be assigned rather than a code from category I-21. In those situations, when you have an old or healed MI that doesn't require any further care, we have code I-25.2, which is old MI, and that may be assigned. Acute myocardial infarction unspecified is the default code for unspecified acute MI or unspecified type. Now, if only a type 1 STEMI or transmural MI without the site is documented, then you're going to assign instead I-21.3, which is ST elevation of a myocardial infarction of an unspecified site. Acute MI documented as non-transmural or subendocardial, but the site is provided, we're still going to code it as a subendocardial. All right, guys, almost done here. I told you this one was a little longer. Subsequent acute myocardial infarction. So when we have a subsequent ST elevation and a non-ST MI, this is to be used when the patient has suffered the type 1 or unspecified AMI and they have a new AMI in that 4-week time period. Here's the thing. A code from category I-22, this is the subsequent one, must be used in conjunction with the code from category I-21, which we talked about. I-21, those are your STEMIs and your non-STEMIs. However, the sequencing is really going to depend on the circumstances of each individual encounter. Do not assign code I-22 for subsequent MIs other than type 1 or unspecified. If your patient has a subsequent type 2, we haven't talked about that yet, but there's more than just a type 1 MI. But if your patient has a subsequent type 2 AMI, we're going to only assign code I-21A1. If they have a subsequent type, such as 4 or 5, we have a code I-21.A9. Now, if a subsequent MI of one type occurs within 4 weeks of a different types, so now we're talking about crossing the different types, we're going to assign the appropriate codes from category I-21 to identify each type. Do not assign a code in this case from I-22. Codes from I-22, guys, should only be assigned if both the initial and the subsequent MI are type 1 or unspecified type. If they're type 2, 3, 4, 5, those other types, you wouldn't use I-22. Speaking of, and lastly, other types of myocardial infarction. So our code set, as you know, we have the type 1 myocardial infarctions, and those are I-21.0 all the way to I-21.4 and I-21.9. But if we have a situation where the patient has a type 2 myocardial infarction, and of note, type 2 is myocardial infarction due to demand ischemia or secondary to an ischemic balance. Those are going to be assigned to code I-21.A1, which is type 2, and then you're going to list a code for whatever the underlying cause is. Of note, do not assign code I-24.8, other forms of acute ischemic heart disease, for demand ischemia. Now, sequencing of type 2 or the underlying cause is going to be dependent on the circumstances of the admission. When the patient has type 2 and it's described as a STEMI or a non-STEMI, you already know you're going to use that type 2 code I-21.A1. Why? Because I-21, those codes are only for, yes, you guessed it, type 1. All right, acute MIs, type 3, 4A, 4B, 4C, and 5 are all going to be thrown over into I-21.A9, which are for other myocardial infarction types. Last note here, guys. You want to follow your code also and code first notes related to any complications and for coding of post-procedural myocardial infarctions during or following surgery. All right, guys, I will be back with another segment where we're going to focus on the respiratory system. Happy coding.